Welcome to Critical Issues in Eye Care, an MD-OD conversation, hosted by Nathan Bonilla-Warford, OD, and J.C. Noriega, MD, MBA. Critical Issues in Eye Care is brought to you by Marco Ophthalmic, a leader in vision diagnostic equipment. Now you know.
Hi, Jay.
Hey, Nate. We have a real treat today. Dr. Dick Lindstrom. He's one ophthalmologist who needs no introduction. He's going to visit with us today to enlighten us in terms of what the thinking from on high looks like. I'd like to welcome you, Dick. It's great to have you on this podcast, and I'm looking forward to talking with you about some of the burning issues affecting ophthalmology.
Pleased to be invited, and I look forward to it. We've had a lot of great conversations through the years, trying to learn how to manage all the curveballs that our government continues to throw to us, and so hopefully we'll have a few useful comments for the listeners.
I'm going to just refer to ourselves as kind of old-timers. It's kind of nice that we're stealing basically another generation's technology in this podcast, but, I thought back before this presentation that you and I are kind of contemporaries in the fact that you were down in Texas honing your skills with Bill Harris, and I was over in Pittsburgh with Frank Hurite trying to learn how to use a phaco machine that is antediluvian at this point, and kind of came up through the ranks and saw a lot of changes in terms of technology. So I'm going to ask you, just in a summary Cliff Notes kind of fashion, what were some of the seminal changes that you've experienced over your career in regard to the performance and outcomes of cataract surgery?
Sure. I began my ophthalmology training in 1972, so more or less committed myself to ophthalmology 40 years ago now, and I actually completed my residency as an intracapsular surgeon. So I think that one of the things that I've definitely learned is that a young ophthalmologist shouldn't expect to complete their career doing the procedures the way they're trained in their residency. And I think that the change continues to accelerate, and those that are going to be the most successful will embrace change and basically revel in it and try to be a prepared mind and basically adapt to it. So I think the young ophthalmologist, and even in those days, I guess I'm amazed at the number of changes. We went from intracap to extracap to phaco, from anterior chamber lenses and iris-supported lenses to posterior chamber lenses. Viscoelastics were added to the mix in our cataract surgery, and now we have lasers as well as advanced technology lenses with multifocal optics, etc., that I couldn't even imagine when I was a resident. And in my corneal surgery, I've gone from full thickness penetrating keratoplasty in most patients to various lamellar procedures in most patients. Glaucoma, I was basically trained to do a Shea thermal sclerostomy, and here we are now doing minimally invasive glaucoma surgery with the glaucose eye stents. And so the bottom line, I think, is expect tremendous change, and the change continues to happen even more rapidly.
Well, you've always been one to keep your finger on the pulse. Have you ever seen a patient who had an intracapsular cataract extraction, Nate?
I saw a patient during my residency, and I saw a few anterior chamber lenses, but those are pretty rare as far as my experience.
Well, one of the things that's been obviously, Dick, is that there have been a tremendously increased level of expectation in our patients in regard to outcomes of cataract surgery. I mean, back in the day, if we got 20/20 with a modest correction of a cylinder and sphere, we were pretty thrilled, as was the patient, and that's changed a lot now. In terms of what you're doing now, what ancillary technologies, what ancillary testing are you doing to help meet the expectations of these patients?
Sure, maybe a couple comments. I was moderating a large symposium at the Academy and asked the audience response to the question, how many people in the audience believe patient expectations have increased during their career, and it was basically unanimous. Everyone agrees that patient expectations have increased. I think it's primarily a generational thing. I'm a student of demographics, if you will, and both our parents, and I'm a baby boomer now, 66 in Medicare age group, but our parents, the great generation, were, I think, much more forgiving. It was more of a whatever you say, doctor approach. They were actually pleased if there was any kind of a treatment for their malady, because in their lifetime they went from usually no treatment available at all to be pleased if there was a positive outcome possible if they had a problem like cataract surgery. And now, basically, I'm the patient, to be direct. So for the younger ophthalmologist, I'm basically your patient. I'm a pretty well-educated, affluent, 66-year-old that's still very active and sharp. I am reading all the time. I'm on the internet. If I have anything that occurs in myself or with my family, I'm looking it up and maybe reading 20 or 30 references, and I'm coming in, pretty highly educated. And then I think I'm knowledgeable that there's a variability in skill levels. There's a variability in technology available between one surgeon and another. And I'm actually looking for, a high-quality surgeon that is going to generate a high-quality outcome. I don't think most of us baby boomers believe that there is no such thing as a complication. But we're pretty demanding in wanting, a surgeon who is going to be well-trained, using advanced technology, and in general generating, good outcomes. And so in our practice at Minnesota we tend to be new technology adopters. We think it helps position our practice as high-tech. I believe as a business person you can be, two of the three major approaches to business are to be high-touch, kind of like Nordstrom's high-tech, or low-cost. And you can be two of those, and we've decided in our practice to be high-touch, high-tech. And I think that's what the typical baby boomer patient, particularly if they're going to share in the cost, is looking for. So we've added a lot of technology. We have advanced diagnostics, including most everything you can think of. Certainly OCT is playing a major role in our practice today in our retinal diagnostics. And in our operating room, we have intraoperative aberrometry. We have actually access to a femtosecond laser. So we're pretty much all in on the technology side, but we also try to be very high touch, which means provide a very friendly, positive patient experience as well.
Well, it's interesting that you should mention that, because just today I had a conversation with our corneal refractive surgeon in the practice, and he had a potential cataract patient who was considering a premium lens go home to think about it, which simply means that they're going to go out on the internet and research it. And sure enough, she came back in with a list of questions, and this was not a young person, but she asked us if we had done corneal topography. She asked us if we had done a wavefront analysis of her anterior segment. The level of sophistication of the questions was pretty impressive.
I would agree, and so it's just, I think what you have to think about, and you and I are in the ballpark the same age, and for our typical, younger millennial, if you will, or Gen X physician associates, the bottom line is that you and I are their patient. So they should expect a pretty sophisticated, demanding patient, and I'm still practicing like you are, and I definitely expect that as well. And I don't find the younger patients that I treat in regards to issues like LASIK to be uneducated in any fashion whatsoever either. They're very savvy and knowledgeable, and also looking, if you will, for the same thing, a very high quality medical experience.
So what questions that do you get where you have patients who have unreasonable high expectations? How do you educate them about what is reasonable in their situation? What tools do you use to bring their expectations closer to a realistic level?
Well, the individual discussion with physician, as always, remains the cornerstone, and most of us tune in pretty quickly to the patient who has unrealistic expectations, and that is just a sincere and honest discussion about what we can do and what we cannot do, and explaining the limitations of the technologies we have, but also arguably the fact that we do have quite advanced technology that can help most people, but we do have to put expectations into context in regard to our ability to generate outcomes, and so we have those issues. But I do find the typical patient desires a lot more education, and I think that's okay. And I actually like an educated patient. I actually take care of a lot of ophthalmologists and optometrists, and I actually, to be honest, I find them in many ways my favorite patients because they are the most knowledgeable, and I think the more knowledgeable, arguably, the better in regards to understanding the strengths and also the weaknesses of any form of medical care.
I love the fact that you emphasize the face time that the doctor has with the patient. Just this past weekend, I wrote an essay for iWorld, and I emphasized the fact that we physicians are in a rather unique position right now because we are really the only people that patients trust in the entire healthcare industry. They certainly don't trust the government. They don't trust the insurance companies. The hospitals are suspect, and it really comes down to that one-on-one, doesn't it?
It really does. It's the doctor-patient relationship, the thousands of years old covenant between physician and patient that in the end matters, and the way that relation is established is face-to-face. It requires talking to the patient. It requires laying on of hands, which in our case is doing a portion of the examination ourselves, such as slit lamp and fundus, and then discussion with the patient. And there's, in my opinion, no way to delegate that.
How often do you see optometrists who refer patients where the patients have had a lot of that discussion already? I think that you're an advocate of strong OD, MD relationships.
I've been an advocate of what I call integrated eye care delivery model, and integrated eye care delivery model includes not just ophthalmologists and optometrists, but also certified ophthalmic medical technologists, opticians, nurses, anesthesiologists, etc. I think we're deluding ourselves if we think the ophthalmologist alone can provide all of the necessary eye care in America as the population continues to age. So I still think the ophthalmologist in general is probably the most highly trained individual in most cases, and most of these integrated eye care delivery models will have the ophthalmologist in the senior position, but it's not absolutely required that they all might. So yes, I'm a big advocate of integrated eye care delivery. We have in our practice 12 ophthalmologists and 12 optometrists, so in our own practice we're integrated. In a given year we'll see at least one referral from about 600 optometrists and about 400 ophthalmologists, because we're all subspecialty care physicians, although we do in our practice some primary and secondary care as well. For me, the better educated the referring doctor and the more time they spent with the patient prior to when I see the patient, the more I like it. So we do a lot of training courses for our own optometrists and our referring optometrists, and we certainly participate as aggressively as we can in the training of ophthalmologists in the current arc, if you will, what we and others are doing. But the more educated, the better, and I love it when a patient comes in and have had a discussion, and again, let's use cataract since that's the most common diagnosis most of us see. They've had a full discussion of all the different lens implants and the options, and the referring doctor, whether it's an MD or an OD, and I see referrals from both, says the patient has selected to have an aspheric monofocal intraocular lens and would prefer monovision with a target of minus 150 in one eye and plano in the other. I mean, I love that. And I still will go over all the options again with the patient to be certain, but I like, that's my favorite referral rather than the one that's never heard of any of this stuff, and they come in and kind of like a deer in the headlights saying, wow, how come my doctor didn't tell me there were all these different lenses, and I feel like I don't, haven't had enough time to think about it, etc. And, in those cases, I often ask the patient to go home and do some reading, and we have a very sophisticated website where there's a lot of information, including videos and animations. We use patient and education concepts and imaginations and some of our own materials. And then, perhaps come back for another discussion. But I love having the referring doctor play, a major role in the education, and when they do, I think it's better for the patient.
I'm thinking that this is probably going to be the first podcast for the new year, 2014. And boy, I hate to end it up this way, but this should be a pretty interesting discussion here, because I think we all have strong feelings about it. And that is, on the Wednesday before Thanksgiving, CMS gifted ophthalmology, vision care, optometry with a real turkey. And that is that the Medicare physician fee schedule was released and showed that our fees, reimbursement, are going to be cut by anywhere between 25 and 27% from current levels. And years ago, I said that I felt that the barrier to be broken as far as ophthalmologists, cataract surgeons looking at doing cataract surgery was going to be the $500 barrier. Well, guess what? It's now $493.62. So, with that great piece of news, Dick, how do you plan to position your practice in light of this? What do you have an antidote, an anodyne for this type of meat cleaver type of approach?
Well, let me say a couple things about that. First of all, I don't think it's going to happen. I think we'll probably get another reprieve, but it's possible that it could. And I've looked at the numbers; it would be a 27% reduction in reimbursement, pretty much across the board, not just cataract surgery, but eye examinations and the like. The reason I don't think it will happen is that if it were to happen across the board, that would put internal medicine and family practice and pediatricians more or less out of business, and no congressman can really afford to do that. So I don't think they care too much about we subspecialists, but an across-the-board cut like that would devastate primary care. So I think we probably will get a reprieve again with a 0 or 1% uptake. But actually, I agree with you, Jay, and that is that, 20 years ago, I was one of the advisors on the RVRBS panel representing the American Society of Cataract and Refractive Surgery. I trundled out to Harvard and got introduced to all the social engineers that were going to plan how medicine was going to be reimbursed. And at that time, I did my calculations, and I estimated that cataract surgery would probably settle at about $500 an eye, exactly what you just said. And as many as 50% of ophthalmologists have said that if it went below that, they would find it financially unfeasible to continue doing cataract surgery. And so we built, at Minnesota Eye Consultants, we built our business plan on the expectation that in my lifetime, cataract surgery would get reimbursed as far as the surgeon fee at $500 an eye. So we're well positioned actually to do okay, even if that happens. I think it won't, and I think we'll still be in the $650 range. But if it does happen, how do we survive? Well, number one, we have an ambulatory surgery center that we own, and I think that's certainly a critical asset. And there's a discussion now whether ASC fees we're going to go up to hospital or hospital down to ASC, but probably hospital down to ASC. ASC helps us a great deal. We do a lot of things that patients pay directly for. We do premium intraocular lenses. We do refractive cataract and refractive corneal surgery, including LASIK and the like. We have two oculoplastic surgeons that do a lot of patient pay procedures. We do some aesthetics work. We own some optical. Our optometrists fit contact lenses. We have both medical ophthalmologists and employee optometry doctors that generate revenues. And so there are things that we have done that are going to allow us to continue to do okay, even at a $500 an eye cataract. But that's not to say that we wouldn't feel it. But if you have a diversified practice and you are participating in some of these other revenue streams, particularly ambulatory surgery center, and particularly some of the direct patient pay options that are available in ophthalmologists. We are much more blessed than most of our colleagues as far as being given an opportunity to continue to be economically viable.
Well, I think if I could summarize, I think that the message to our colleagues, both ophthalmic and optometric, is to try to nurture as many revenue streams, cash revenue streams, as you can in your given circumstances to offset the inevitable cuts that we face in the third-party market, third-party reimbursement.
I would point out one other thing. The biggest risk to the typical comprehensive ophthalmologist or optometrist, particularly if they're in a solo practice, I believe the biggest risk to them that's coming is that they'll be excluded from being a caregiver in some environments. And while it's just beginning, we went through this once before when the HMOs tried to do it, and then we got what's called any willing provider laws, where people were bailed out by saying that they would accept the terms that someone else accepted. They could be in a provider network. But I don't think that's going to happen this time around. So the new three-letter word rather than HMO is ACO, the Accountable Care Organization, and they are starting to exclude a lot of the providers from networks around the country right now. And so if you're kind of the big gorilla, which is another reason we built a large group at Minnesota Eye Consultants, but we not only did that, we partnered with 3 other large groups in our city, more or less so we can't be ignored and almost impossible to exclude us. But there is some risk, I think, for the smaller individual practice, solo ophthalmologist, solo optometrist, to just all of a sudden not be on the panel and patients can't come to them anymore. And I see that as a big risk for them.
Dick, I congratulate you for your foresight. I think that consolidation is certainly in our future. But I'm curious, has the size of your practice and the way you've positioned it, do you find you have any leverage with third-party payers? Will they talk with you? Will they sit down with you?
Oh, some will and some won't. So you obviously cannot negotiate with CMS as an individual doctor, and so that there's no way to negotiate there. And I mentioned before, you want to have a higher percentage of patient pay if possible, and if it's patient direct pay, obviously you can negotiate there, and sometimes we end up doing some negotiation and giving discounts, etc. But with the bigger payers in our area, we have found that a practice like ours actually can negotiate. So we one of our biggest payers in our region is Blue Cross Blue Shield, and we have found that if we provide what they need, which is good value, meaning high quality care for their patients at a fair cost, that we can negotiate with them. And I think there will be more and more of that kind of negotiating going on. An ACO can be, as I understand it, a few doctors all the way up to something like a Kaiser system. But I would just encourage the ophthalmologists to get educated about this, realize they're probably going to have to be in some kind of a network to survive what at least the Accountable Care Act has in mind for us. And I don't think we're going to get the reprieve this time that we got the last time.
I agree. I think education is important. There's a lot of discussion going on in the eye care circles I'm in, and I think some people are being very proactive to try to figure out how they can leverage the networks they're in, and some aren't. And I think that's going to be very critical in the next coming years. So we'll have to see how that works out.
Well, I'd like to close my end of the discussion with just some brainstorming here, in the sense that I'm curious again, because I'm noodling this possibility that I might end my career as a physician who doesn't participate in the Medicare program. Has that ever crossed your mind, Dick?
Well, I think there are a lot of very well-established, senior, if you will, ophthalmologists who are starting to consider that option. And I think that's actually making our governments a little bit nervous because we probably actually, we have less ophthalmologists every year, And the concern is that, we baby boomer ophthalmologists either opt out or retire early. There won't be a large enough cohort of really quality people to provide the kind of care that our government is promising everyone. I personally haven't thought about that, and I don't want to sound too much of a Pollyanna or too altruistic here, but I'm a fourth generation Minnesota Swede living in my the community where I grew up, and I really do believe one of the reasons I'm there is to serve the community. That doesn't mean that I'm going to be stupid about all these things we've talked about, and I've certainly tried to be a good business person and position ourselves so that we will survive. But we do end up doing a lot of care below what it costs us. But fortunately, we've been able to figure out to do enough care above what it costs us that we can continue to, just serve the community. And it may get to the point where we'll have to change that. But for now, I make myself, equally available to the, the worst paying patients, and in many cases actually do surgery at no charge when needed. And I'll probably finish my career that way, but that's easy for me to say because I'm in my last, 5 to 10 years.
Well, that's great, and I really enjoy this conversation. I look forward to our paths crossing yet again at some point in the future, because you always make me think.
Yeah, thanks for joining us. I certainly learned a lot, and I look forward to talking to you next month, Jay.
This broadcast is sponsored by Marco, redefining the art of refraction through superior understanding of every patient's total visual system. The Marco extraction process combines wavefront technology with digital refractions to deliver outstanding practice efficiencies and optimized patient experiences.